Endocarditis, our next section. Endocarditis is defined as a heart valve infection that leads to a fever and a murmur, or a murmur and a fever. The diagnosis can be based solely on two major criteria, which is positive blood cultures and visitations on an echocardiogram. It would be rare to have endocarditis on a normal heart valve, except for injection drug users, IDUs. That is because the valves are covered with a endothelial lining that is very tough. It resists things, but the Staph aureus in an injection drug user melts through it. It's like taking tennis balls soaked in gasoline, lighting them on fire, and throwing them up against the wall. That's what Staph aureus is. Coagulase positive staph. Coagulase positive staph is synonymous with the word Staphylococcus aureus. And the coagulase is the enzyme that is a genetic advantage for the staph because it melts into tissues and allows it to penetrate. The risk of injection drug use is that it's able to melt through what is anatomically normal linings. The other forms of endocarditis have to have a break, a nook, a cranny, a damage, a break in the endothelium. The risk is proportional to the degree of damage to those valves, and regurgitant and stenotic lesions have an increased risk. Prosthetic valves are the highest risk because they are anatomically the most abnormal. They don't have the normal endothelial lining, so therefore they're vulnerable to invasion by bacteria. Endocarditis can develop in normal heart valves if there is a very severe and persistent bacteremia. It's one of the key features of endocarditis, persistence or sustained bacteremia. The pathogenic organisms like Staph aureus. Viridans group strep is rather wimpy compared to Staph aureus. Dental procedures with blood are a very small risk. This is something over the last 5 years we've realized that all that anxiety about dental procedures was misplaced and exaggerated. It's a very small risk. Surgery of the mouth and the respiratory tract confers no risk unless there's severe valve disease. Artificial valves and cyanotic heart disease. Cyanotic heart disease in particular has a risk because there's a tremendous abnormality of turbulence. Endoscopy confers no risk even with a biopsy. Now, that's any form of endoscopy you can think of. Bronchoscopy, colonoscopy, sigmoidoscopy, even with a biopsy, even ERCP does not confer a risk of endocarditis. It just doesn't. The key to the most likely diagnosis question is a fever combined with a murmur that's either new or changes in intensity, becomes louder. The complications of endocarditis are rare, such as splinter hemorrhages, like you see in this picture here, underneath the fingernails, Janeway lesions, which are flat and painless. These are lesions that occur with untreated bacteremia from endocarditis. Some are embolic, and some happen as a immune phenomena. They're useful mostly in those patients who have negative blood cultures, but you think they still have endocarditis. The embolic phenomena, or rheumatologic phenomena, help you in establishing what is the most likely diagnosis. The presence of Osler's nodes, which are raised and painful, or Roth spots in the eye and not visible from the outside. You've got to look in the back of the eye. They're a retinal finding. Inside the brain, the unfortunate term mycotic aneurysm is not from a fungus. The word mycotic aneurysm, which can be easily confused with a fungal related aneurysm, simply means the weakening of a blood vessel in the brain that occurs from infection or embolic infection, little embolic bits of fibrin plaque flying off of your heart valve, flying into the brain and damaging the wall. And it can make people bleed into their brain because it invades the wall of those vessels and weakens it and they rupture. Ouch. Kidney problems, hematuria, and glomerulonephritis because the bacteria and the infection literally clog up your glomeruli. Now, one of the most amazing things is that endocarditis in the pre-antibiotic era, or in people who don't have access to antibiotics, interestingly enough, is 100% fatal. You know what that means? 100%. Tuberculosis only kills 2% of people who get it. HIV, even untreated, kills 95 or 97. Plague kills a third, but endocarditis is the most fatal infectious disease there is. However, it takes a long time to get there, and you know how you died? Renal failure without treatment. The wrong answer is valve problem. The most common cause of death without treatment is hematuria Glomerulonephritis is kind of like post-strep glomerulonephritis, damages up those kidneys. You should expect to see red cells inside the urine if you have untreated endocarditis. Conjunctival petechiae are called conjunctival petechiae. They don't have a name to them like Osler's nodes or Roth spots. Splenomegaly happens because the bacteria get caught in the spleen. They grow there. They enlarge the spleen. It's painful. And septic emboli to the lungs is what can make a person look like they're presenting with a fever and a murmur and simultaneously with a pneumonia. Signs of embolic phenomena don't change management in the general case. You're still giving 4 weeks of antibiotics in most cases. These embolic or immunologic phenomena are critically important in the person who has vegetations but has negative cultures. Perhaps the person got antibiotics. It's described as getting antibiotics, and the cultures are falsely negative because they got antibiotics before the blood cultures were drawn. How do you establish a diagnosis? Vegetation, fever, risk, and one of these embolic phenomena. Not all of them, but one of them. Here's a good question for you. Which of the following is the most common? Which of these are the most common embolic phenomena? And the answer is the splinter hemorrhages on the previous page. Splinters are the most common. A person has a fever and a murmur and a fever, and you suspect endocarditis. What is the best initial test to establish the diagnosis? The first test is blood cultures. Blood cultures have a 95 to 99% sensitivity. That means the false negative rate is 1 to 5%. Do that first. Negative blood cultures has an extraordinarily good negative predictive value. The wrong answer is doing an echo first. The echo is not first because transthoracic echo only has a 60% sensitivity. That means the transthoracic will miss 40% of cases. And then people sometimes say wrongly, well, why not just do a transesophageal first? One, you're not putting yourself in the position of the patient who wants to have a transducer put down their throat into their esophagus right away. Wrong, not first. Blood cultures are first because they're much more sensitive. If the blood cultures are positive, then you do the echo. Blood cultures, then transthoracic echo if positive, and if the transthoracic echo doesn't show the vegetation, then you transesophageal echo. People have been getting this wrong as saying echo first. Wrong! For the more than 20 years that I have been doing Step 2 classes live. And in the thousands and thousands through the live class, the wrong answer has always been the same. Echo, not first. The EKG shows nothing most of the time. A small number of people, 5 or 10%, will show a heart block. EKG rarely shows AV block, and if it's dissection of the conduction system as it dissects through and cuts it, but it's unusual. Fever and a murmur equals endocarditis. Blood cultures should be obtained first. If the blood cultures are positive, do the transthoracic echo. Positive blood cultures and a vegetation on transthoracic echo equals endocarditis. A man comes into the emergency department with fever and a murmur. Blood cultures grow Streptococcus bovis. Transthoracic echo shows a vegetation. This person has endocarditis. Period. Thank you. What's the next step in the management of this patient? Clear endocarditis. What do? Well, it's colonoscopy. We're doing colonoscopy for looking for sources of colonic pathology with strep bovis. And this is a question that you'll know and you'll be asked for a reason that nobody understands. One of the streptococci, why should bovis come out of the colon? Nobody knows. It's associated with colon cancer. It really is. You don't need the transesophageal echo if the transthoracic already shows the vegetation. The transesophageal echo is done for more sensitivity if you have a potentially falsely negative transthoracic. You don't need the transesophageal if you already got a positive transthoracic. So therefore, since the transthoracic showed the vegetations, go straight to treatment and colonoscopy. CT, the abdomen, essentially is useless. It won't show diverticuli. Repeating the blood cultures is useless because you know you have positive blood cultures. There's no point. They're already positive. And surgical valve replacement is simply not necessary. It's premature because strep bovis may be associated with colonic pathology, but it's not that pathogenic. Strep bovis is so frequently associated with colonic pathology and colon cancer that in the 1940s you can find papers where they actually said, we have found the cause of colon cancer. It's strep bovis. They actually thought it caused cancer. The diagnosis of endocarditis is positive blood cultures and a vegetation on an echo. That's it. Done. But what do you do if the blood cultures are negative? Well, here's how we get those 1 to 5%. You see the oscillating vegetation. It's out on a stalk, like a lily or a rose flopping around on a stalk. And then you find 3 other criteria. Well, fever, a major risk like injection drug use or prosthetic valves. Injection drug use boluses you with tons of bacteria and melts through, and prosthetic valves are simply vulnerable because they don't have the normal layer of protection that my heart valves have. And the last thing is one of the embolic phenomena. Now, it doesn't have to be all of them. It could be a fever and the risk, and a Roth spot, or a Janeway lesion, or splinter hemorrhages. And when you combine the abnormal echo with 3 minor criteria, that would confirm endocarditis. Now, the number of people with culture-negative endocarditis is becoming very small, and that is because our culture mechanisms have improved. Since our culture mechanisms have improved, this is, in many places, only 1 or 2%. You take the blood cultures and you give treatment while waiting for the results of the blood cultures, vancomycin and gentamicin. A person comes in with a fever and a murmur and a murmur and a fever and a fever and a murmur and a murmur and a fever. I take the blood cultures and give vancomycin, and when the culture results are available, I switch them based on the sensitivities. If it's a nice sensitive strep viridans group strep, we switch it to ceftriaxone. If it is MRSA, we continue vancomycin. But start with vancomycin and gentamicin as empiric therapy and change based on sensitivities. Here's where we start to kick this grade up. Viridans group streptococci, knowing the specific treatments for it, ceftriaxone or penicillin for 4 weeks. Ceftriaxone is simply easier to give, but ceftriaxone, penicillin, or ampicillin for 4 weeks of therapy. Now, viridans is a group of number of organisms. Sometimes you may hear them called mutans, malari, midior, salivarius, sanguis. So when you hear those 5 names of mutans, midior, malari, sanguis, salivarius, those are all the 5 different subtypes of viridans group strep. I have not made a big thing of it in the book because it's not as important, because it doesn't change the answer to the question. Best initial test, blood cultures. Blood cultures and echo, you have endocarditis. And the treatment question, which is empirically vanco and gent, and then ceftriaxone for 4 weeks. Since it doesn't change the answer to the questions, if it's not going to change the answer to question on step 2, you're not going to find it in our book. Staph aureus that's sensitive gets oxacillin, nafcillin, cefazolin. These are all totally equal in efficacy. And if you do your 3rd year in one hospital and you go do rotations in another hospital for your 4th year, and you say, gee, why did that hospital use oxacillin and this hospital use nafcillin? It's simply dealer's choice. They're essentially equal. So fungal endocarditis, not only is it a reason to do valve replacement more often, they do better with valve replacement, amphotericin. That's one of the last remaining indications for amphotericin. We're very fussy about the heart, very hard to treat cardiac infections. So amphotericin for cryptococcal meningitis and amphotericin for fungal endocarditis may be the only 2 truly clear indications for amphotericin, and maybe mucormycosis. But that's it. Working backwards from the when is this drug the answer? Amphotericin. Fungal endocarditis, cryptococcal meningitis, mucormycosis with diabetics having their faces ripped off with black fungus. Work backwards from the answers. When is this drug the answer? Is a lot easier. The treatment of organisms such as Staph epidermidis or resistant staphylococcus like MRSAs with vancomycin alone. You do not need to add gentamicin to the vancomycin. It's vancomycin alone. Enterococcus is a combination of ampicillin and gentamicin. The ampicillin is a cell wall active agent that will break a hole in the cell wall, and gentamicin is quite synergistic by damaging the ribosome. Now, for some resistant organisms, you add aminoglycosides and extend the duration of therapy. That's predominantly for Enterococcus, which needs 6 weeks of therapy. When is surgery the answer? Well, surgery is the answer for the most serious form of endocarditis, which is unquestionably a ruptured heart valve or chordae tendineae. You cannot reverse a rupture of a valve or ruptured chordae tendineae with antibiotics alone. So therefore, shortness of breath, rales, edema must be treated with surgical repair immediately. Also, when surgery is to be done, it must be done quickly because there's no such a concept of let's soften up or treat the endocarditis for a while, then replace the valve. No, quite the opposite. When you replace the valve surgically, you've effectively cured the endocarditis. It's gone. It's removed. And while you're waiting, if you are waiting to treat it for a while, they can get embolic phenomena and get much worse. Prosthetic valves do better with surgery. Fungal endocarditis, abscesses certainly do better with surgery. People with AV block tends to imply a bit of an abscess inside there. And recurrent emboli while on antibiotics. No one wants to wait around and see if they get another embolus to their eye or brain. So all of these are things where people do better with surgery because you cure it, and the ruptured heart valve is the strongest indication for surgery. Besides doing better with surgery, prosthetic valve endocarditis is an indication to add rifampin. We believe that it creates greater synergy and tissue penetration for prosthetic valves. The single strongest indication for surgery is that rupture that is stronger than just having a prosthetic valve is the rupture. The most common cause of culture-negative endocarditis is Coxiella burnetii. It is not the HASIC group. HASIC group, which is an acronym for organisms that are difficult to culture causing endocarditis, such as Haemophilus afrophilus or Haemophilus parainfluenza, these used to be the most common cause, but the culture methods have improved and we're able to detect them more easily. The reason I'm making a particular note about this is that it is the most common wrong answer to say the HASIC group. That is the most common wrong answer. That's old. Coxiella and Bartonella quintana. Bartonella and Coxiella are the most common cause of culture-negative endocarditis, and that's because they are very difficult to culture on blood. You use non-culture methods such as complement fixation, PCR, or serology. HASIC is Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. When you do have the HASIC group, the answer is ceftriaxone for treatment. Again, I must emphasize that when it says which of the following is the most common cause of culture-negative endocarditis, trust me, don't say HASIC, say Coxiella and Bartonella. When is prophylaxis for endocarditis indicated? Well, this is a subject that has been fraught with difficulty for the last several years because there's been a lot of changes. It's been reduced. You use prophylaxis only if there's both a significant cardiac defect, such as a prosthetic valve, or previous endocarditis, or cardiac transplant recipient, or unrepaired cyanotic heart disease. And it has to be both one of these anatomic defects and a bacteremia-causing procedure, higher risk of bacteremia, such as dental work with blood or respiratory tract surgery that produces a bacteremia. It has to be both a cardiac lesion that has a greater risk of endocarditis and a procedure with significant bacteremia. When you are going to use prophylaxis, it is amoxicillin prior to that procedure. If you're penicillin allergic, clindamycin, azithromycin, clarithromycin are all acceptable. That's not a problem. That's not changed. Procedures and anatomic abnormalities that do not need prophylaxis. No scope, no flexible scope needs prophylaxis. Even with biopsy, an ERCP no longer needs prophylaxis. OBGYN procedures of any kind, IUD placement, vaginal hysterectomy, abdominal hysterectomy, no form of OBGYN procedure ever needed endocarditis prophylaxis because those bugs that are in there are relatively non-pathogenic. They're not going to hurt you. Urologic procedures do not need prophylaxis. That even means a prostate biopsy. No. Mitral valve prolapse, even with a murmur, and all of these valve lesions, again, do not need prophylaxis. Even if you have dental work with blood, you must have two things to need prophylaxis: significant valve lesions, prosthetic, previous endocarditis, unrepaired cyanotic heart disease, transplant recipients, and dental work with blood or cutting the respiratory tract with bacteremia. None of these things are indications. Make sure you learn it.